as well as advanced procedures in the colon and the rectum. Dr. Aslanian was trained at Yale after doing his residency at the Mayo Clinic, and we're very excited to have him speak tonight.
Thanks, Ann. It's a great pleasure to be with everyone tonight. We're just going to start off looking at our screening options for colon cancer. Let me share my screen here. Can we have this one? And let me put that in slideshow. Okay, how's that look? Is that all right? So colon cancer screening, just minimize this. So it's important to recognize that colon cancer equally affects men and women. There's about a 1 in 25 lifetime risk of colon cancer. So it's a fairly common. And that's why we screen all individuals regardless of family history. And we are seeing an increase in colon cancer in younger patients for not entirely clear reasons. We think diet and activity have something to do with it, but it's actively being researched. And that's why the age that colon cancer screening is started for average risk individuals has been reduced from 50 to 45 years of age. So what factors increase an individual's risk for colon cancer? So we take into consideration a family history of colon cancer, how many individuals, what their relationship is. So are they a first degree relative or more distant relative? What age did that develop in those individuals? Other factors that increase your risk for colon cancer would be cigarette smoking, obesity, physical inactivity, prior history of radiation. If you've had other cancers that might be associated with a genetic syndrome that might put you at increased risk for colon cancer, such as cancer of the uterus or ovaries. If you have a chronic inflammation of the colon, what we call colitis, such as ulcerative colitis or Crohn's colitis, and we know that African Americans have a higher risk of colon cancer. So what are the symptoms and signs of colorectal cancer? It's important to remember that most early colon cancers produce no symptoms. So we're not looking for symptoms. That's why we screen the entire population currently at age 45. If you do have symptoms, it's important to report those to your healthcare team. And these are some of the symptoms that would be particularly worrisome. If you have blood in the stool, a change in bowel habits, if you notice a change in the consistency of the stool, if you're having rectal pain or abdominal pain, weight loss, and anemia, which would be a low red blood cell count, which could possibly be due to loss of blood in the stool. And like we said, it's most individuals who develop colon cancer is what we call a sporadic cancer, means that it develops just as a first-time event. So most people that develop colon cancer don't have a family history of colon cancer. So you don't have to have a family history of colon cancer to benefit from screening. And colon cancer is unique in that we can actually find a precancerous polyp and remove that and take away the chance of it ever becoming a cancer. So this picture shows you where the colon sits relative to your abdomen. Here's the rectum, the lower part of the colon, and we call the left colon. It comes up kind of like a horseshoe across the abdomen, the transverse colon, then the right colon. And there's different names for these parts of the colon. Like we talked about, it starts down in the left lower side and then ends up in the right lower abdomen and what we call the cecum, and the appendix hangs off of the cecum. So colon cancer starts as a benign growth, as a polyp, which is a precancerous growth. And polyps start small and then they grow larger. And we have a unique sort of scenario where we can visually see precancerous lesions and then remove them through the colonoscope. And then once they're fully removed, they never have a chance to progress to a cancer. Colon cancer from ever developing. And not all polyps will turn into cancer, but pretty much all cancers start as a polyp. And polyps typically grow quite slowly. It may take an estimated 7 to 10 years for a typical polyp to progress to a cancer. And it's interesting that our understanding of how cancers develop and the types of mutations that are accumulated that cause a precancerous growth to become a cancer was that understanding was helped formulate based on colon polyps and this visual representation of a larger polyp accumulating more mutations as it progressed to a cancer. So currently, colorectal cancer is the second most common cancer. And fortunately, it is one of the most preventable types of cancers. And we're seeing reductions in the rates of colon cancer with the increased utilization of screening. So what do screening tests do? They were basically looking for precancerous polyps so they can be removed before they turn into cancer. We can also identify, cancers in any condition as well. So how does colonoscopy do that? Colonoscopy visually examines the colon for polyps. We can also look for signs of polyp with a stool test. So we're either looking for blood that's released by a polyp into the stool, what we call a FIT test, or a DNA fragments of the polyp that's in the stool, what's known as a Cologuard. And then if these stool tests are positive, then that would trigger your doctor to recommend a colonoscopy to directly look for polyps. So those are the two ways to approach screening. Here's an example of a endoscope. It's a flexible instrument. There's a light in the camera at the end of the scope, and we can infuse air or carbon dioxide into the colon and directly examine the colon and remove polyps through this scope. Colonoscopy requires a bowel preparation. This typically involves liquids the day before, and then you drink a solution the night before that cleans out the colon. Typically, anesthesia is given through an IV, and you require a ride home after the procedure. It's very low risk, less than 1 in 1,000 risk of injuring the wall of the colon by passing the scope. And so here's an example of some of the things we can see during the colonoscopy. Here's a normal colon. You can see the multiple folds and how clean the colon is after the preparation. Here's a small polyp, and then this would be a colon cancer. If this polyp were to sit there for a decade or longer, it could grow larger and then develop mutations that might lead it to progress. So when we see a polyp at colonoscopy, we can remove it through the scope. And once it's completely removed, that prevents it from ever having a chance to progress. So at the time of colonoscopy, as you see, we can look for polyps and then remove them at the same time. If we choose to do a screening test that's based on the stool, that would be assessing for signs that there may be polyps in the colon or an early cancer, such as that FIT test. It stands for fecal immunochemical test, looking signs of blood in the stool. And then this is typically performed once a year. And if that were to be positive, then your doctor would recommend a colonoscopy for further evaluation. Another way to approach this, like we talked about, would be to look for fragments of polyps with their DNA fingerprints in the stool. This is a little bit more sensitive test than the looking for blood alone. So approximately 90% of cancers and about 40% of larger polyps can be found with this type of DNA test. And then similarly, if this is positive, then a colonoscopy would be recommended to look for and remove polyps. Other options include a special type of CT scan. It still requires a preparation and insufflation of some air. But if for some reason you're unable to undergo colonoscopy or colonoscopy can't be completed, that's an option to do a special type of CT scan. And then similarly, in incomplete colons, you can swallow a pill camera that we sometimes use to look at parts of the colon that were unseen. So then, what are the current recommendations for screening? So in average risk individuals, so we assess the risk based on someone's personal history, if they've ever had precancerous or adenomatous polyps, or a personal history of colon cancer or other cancers. And then also we assess the family history. Have you had first-degree relatives or other that have had colon cancer? So an average risk would be meaning that you've never had significant polyps and you don't have family history of colon cancer. Then it's recommended to start screening at age 45 with one of the tests that we talked about. As we, with screening tests, as you get older, the benefit may be reduced. So as a rough sort of rule of thumb, we might consider the risk and benefit of continuing screening past age 75, although age is such a relative number and so dependent on someone's overall health status. So then the primary screening methods for screening for colon cancer that for average risk individuals would be a schedule of colonoscopy every 10 years, or that FIT stool test every 1 year. Other good options include that DNA stool test, which would be done every 3 years. A sigmoidoscopy is a shorter scope that looks at only the left half or lower half of the colon. That could be done every 5 to 10 years in combination with a stool test looking for blood. And then we talked about less commonly the options of a CT scan or capsule are available. You may have heard in the news recently, there's been some progress in blood tests that can look for fragments of colon cancers. While this is exciting technology and improving, it's currently not recommended for screening. And then this is currently only able to detect a cancer and not a precancerous polyp. So really doesn't have a role for screening yet. And we talked about how we assess family and personal history of polyps or colon cancer. So if you have a family history of colon cancer, we would typically think about starting screening at age 40 or 10 years before the age that cancer developed in the family member, whichever comes first. And then we typically repeat a colonoscopy roughly every 5 years instead of 10 years based on the family history, and sometimes even more frequently if there's even higher risk genetic findings or chronic colitis. So it's important to inform your doctor if you have a history of colon cancer or other cancers, and genetic testing or consultation with a genetic expert may be suggested. If you yourself have had a personal history of adenomatous or precancerous polyp, then we often would also repeat a colonoscopy in 5 years instead of 10. And then after, if someone should develop a colon cancer and after it's treated and resected, we typically would then pursue colonoscopy roughly 3 years after resection, and then every 3 to 5 years after that. Great. Well, thanks so much, and I appreciate the opportunity to join you tonight.
Thanks so much, Harry. I really appreciate that. I don't see any questions in the chat just yet, so we'll move on next to Dr. Nagar, who is one of our amazing gastroenterologists here at Yale, also in our advanced endoscopy division. He's also an expert in minimally invasive techniques and such as endoscopic submucosal dissection to remove large polyps. Dr. Nagar?
Thanks. Can you see my slides okay?
We sure can.
Okay, thanks. So thanks for inviting me to talk to you. And I think it's an exciting time for doctors who treat colon cancer. And these are 3 slides I have for you. I'm just going to echo a lot of what Dr. Aslanian said, and with a couple of questions that gastroenterologists are usually asked, and then about what we can potentially offer. So the first part of this slide shows you how rates of colon cancer are coming down. You can see the rate is coming and mortality is coming down. And we can argue whether we're actually becoming healthier as a population. And if we're the same or perhaps not getting much healthy, something else is doing that. And that something else is screening. And so I'll echo that actually screening works. I am much less likely to die of colon cancer because I've had my colonoscopy or my screening test. The second is actually all of you in the audience, I presume, are from Connecticut, and Connecticut is doing very well. If you look, we are right at the other end of the second graph with almost a 70% screening rate. So that's great, but we could do better. Everyone can do better. So we are one of the top states in the nation for screening. And the last part of the slide and the last graph is the not good news, and that is that colon cancer is increasing in young patients, in the 40 to 50-year-old. We used to see it as a peak incidence at 70.
If you can go to full screen.
Are you seeing me now?
It's still just showing the,
Now?
there you go.
Okay, thanks. So I just want to talk about the role of the gastroenterologist. The gastroenterologist is someone who is a consultant in GI disorders. And when you see a gastroenterologist, generally you start with your primary care doctor who talks to you about colon cancer screening. And I just want to reiterate, there's no best test for colon cancer screening. You should do what you're most comfortable with, whatever that test is. But if you see a gastroenterologist, they might talk to you about colonoscopy as one of the tests for colon cancer screening. There are advantages and disadvantages to all of them. When you see a gastroenterologist, we would definitely talk about your family history and categorize your risk based on that. We talk about different ways to screen, and then we talk about colonoscopy. And I think a simplistic way to think about colonoscopy is, unlike other tests which are geared towards finding cancer, colonoscopy is geared to finding a polyp. Our understanding is if we do not have a genetic predisposition or a syndrome, it takes about 10 years to develop a cancer, 5 to 10 years. So if I can take the polyp out before that time, patient shouldn't get cancer. And a simple way to think about it is when you see a dermatologist and look at the skin for lumps and bumps, and you cut them out before, for instance, a melanoma develops. So it's the same way to think about it. The other thing about colonoscopy is that it's not a test that's just looking for polyps or cancer. It's looking and it's removing. So after you undergo such an examination, you should be at significantly less risk of cancer. The next thing is, it is actually the first test recommended in certain patients, like Dr. Aslanian said, who have high risk of cancer. Also remember that if I decide to do a stool test and my stool test is positive, I will require colonoscopy. And lastly, there is risk involved with colonoscopy, and your gastroenterologist is going to talk to you about that risk. It's low, but it is a small risk involved, and it tends to be involved with removal of polyps. Also, another reason some patients see gastroenterologists is because now they have symptoms. So most polyps have no symptoms. Early cancers may not have symptoms, but if you have symptoms of bleeding, pain, weight loss, anemia, you will see a gastroenterologist. And once again, polyps don't cause symptoms. And so when we're doing a colonoscopy for screening, we're doing it in someone who has no symptoms. And these are pictures of polyps, different types of polyps, and how
Dr. Nagar, we're still not seeing the full screen. So I think we're still seeing your colon cancer impact of screening slide right now. Slide 2.
Are you seeing it now?
There you go.
Are you seeing you're seeing it now?
Yes.
All right. Yeah, I'm sorry. All right. So here is I'll play this video as we're doing it. When polyps are larger or flatter, it requires certain types of techniques to remove them. This might be available in your local hospital, and sometimes your doctor might refer you to a tertiary care center for removal. And this is one of the easier techniques that we use, where we inject substances in the colon under the polyp, raise it up to ensure that there's complete removal of the polyp, and that reduces the risk of both recurrence and cancer for the patient. this is just a scheme and some pictures and a cartoon to show you the depth of what can be done in terms of dissecting out lesions from the colon. If unfortunately I had a cancer, I would see a surgeon who cut the whole colon out and reconnect it. Whereas what we're trying to do as gastroenterologists, find the patients early with polyps that can be removed, either with a snare, and that we would go to certain depths within the colon, or use certain techniques on the right side of the screen where we would use a knife endoscopically and slowly dissect out a tumor, a large polyp, or very early polyp developing into cancer, and take it out, preserving the wall of the colon and the muscle of the colon so it could heal, and potentially trying to avoid a surgical procedure. And these would be certain types of patient in a multidisciplinary setting where we decide that an endoscopic approach might be best for the patient for both curing the patient and reducing the risk of cancer in the future. I have this one slide about early onset colon cancer, and frequently asked about it. And this is onset of colon cancers in patients around the age of 50 or less than 50. And so, as Dr. Aslanian said, we have now recommended in the United States to screen patients at age 45. But if I'm a patient and I have a relative who had cancer at age 45 of the colon, then I should be screened 10 years before that. We don't understand why these colon cancers are increasing, but what we do know is that they tend to occur on the left side of the colon. What does that mean? That's the area close to the rectum. So they tend to cause symptoms. And those symptoms are pain, change in bowel habits, bleeding. And so if the young patients have this symptom, they should see their doctor immediately. And there is some evidence that there's significant delays from the patient because they say, oh, I'm young, there's no way I can have cancer. And delays from the doctor, perhaps saying that perhaps this is a hemorrhoid, there's some other reason. And so it's important we all educate ourselves about it and we take these symptoms seriously. The molecular profile is slightly different on these cancers and suggests maybe an inflammatory pathway. This becomes important because some sort of medication therapy might be different for these patients, the chemotherapy. We don't understand why this is occurring, but it could be, dietary changes in very young children, and as we grow up, or antibiotic use, or something about environmental factors, few food additives. A lot of research is going into this. If I have a polyp, then I need to follow up with a colonoscopy with my doctor. And these are some of the intervals that are suggested. If I have no polyps, then 10 years is generally an interval that's suggested. And if I have many polyps, a very large polyp that was taken through the endoscope, 20 or 30 millimeters, then perhaps I should be seen in 6 months to a year's time, again with a colonoscopy. A frequently asked question by patients is, I've done a test. It's a positive test for blood in my stool or DNA in my stool. And I'm unable to get to my colonoscopy. How long can I wait? I have to travel, I have a wedding. While there's no good answer, you should have your colonoscopy right away. But there's some evidence in the literature that should we delay it beyond 3 months, and definitely beyond 6 to 9 months, there is a difference in the finding on colonoscopy. We tend to find more advanced lesions. And so recommendations are best to have your colonoscopy within a month, but or up to 3 months. Try not to delay it more than 6 months after a positive test. On the other hand, if you're having a colonoscopy follow-up, a 3-year follow-up, and if you delay that by a few months or half a year, it probably has very little impact on the patient. And then we also frequently ask as gastroenterologists, how can I prevent colon cancer? Well, it's interesting. It's just healthy living. There has to be an interaction between your food and your colon, unlike maybe lung cancer, or perhaps breast cancer, or prostate cancer. So it's really what you eat, and just keeping a very healthy diet, limiting your intake of red meats, fats, butter, charcoal broiled, or salt cured food. There's some evidence that vitamin D supplementation and high calcium intakes are better and better for the colon and reduction of colon cancer. And just generally being active, keeping your weight within a normal range, limiting alcohol and smoking, all tend to be positive effects. There are less polyps in these patients and less cancer in patients. And so generally, just the take-home point from the gastroenterology standpoint from screening is that colon cancer really screening saves lives. And for all of you in the audience, if you're 45 years older, I hope you've had some test for colon cancer. There's no best test. The best test is what you get done. And there are advantages and disadvantages, and that's why you need to talk to your doctor about screening. Don't ignore any symptoms of rectal bleeding, pain, weight loss, change in bowel habits. Consult your doctor or your gastroenterologist, someone about this. Colonoscopy has a special role in screening and treatment. And then patients who've had polyps or cancer are needed for surveillance. And then in tertiary care centers such as Yale, there are some advanced endoscopic procedures that can be offered to certain patients to remove larger polyps or larger growths in the colon and potentially to avoid recurrence of them, avoid cancers, and avoid surgery. Thank you.
Thanks so much. I don't see any new questions yet in the chat area, so we'll keep going forward. And I'd like to introduce my colleague, Dr. Haddon Pantel, next. He's one of the colon and rectal surgeons here at Yale. He came to us by way of the Leahy Clinic. Dr. Pantel.
Before I get started, can you guys see and hear me okay?
You sure can.
All right. So whoever's running the presentation, I'm just going to be talking, got a whiteboard back here. And my idea is to sort of take you guys through if you were to see me in clinic. And so say you had seen Dr. Nagar or Dr. Aslanian and you had gotten that colonoscopy, whether it was for screening or for symptoms, and say you're in the unfortunate situation of they have found a cancer and a referral is placed to a surgeon. So I'm going to give sort of the talk that I give my patients about what is surgery, what is the workup, what to expect after, immediately, and then when you go home and what to do next. So if you're one of my patients and you're watching this, or one of Dr. Mongiu's patients, because I'm sure she gives a very similar talk, I apologize for the redundancy. So the first thing I just want to talk about is basically just the anatomy, the plumbing. Sometimes I joke I'm like a fancy plumber, though I'm probably not that fancy. But I think the first thing to think about is what's the plumbing, so to speak. So can you guys see this okay? Yeah. So first stop after you eat food is the stomach. Think of it like it's a thick muscular organ. I like to use the analogy, it's like a blender. So your teeth do a lot of the grinding and things like that, but the stomach actually finishes all that. And when the stomach's done with it, it goes to the small intestine next, okay? You have probably about 20 feet of small intestine, sometimes 20 to 30 feet. It's variable in different people, but it just sloshes around the belly. I like to say it's like spaghetti in a pot of water. It's freely mobile. The job of the small intestine is essential. It's really what keeps you sustained. When you think about nutrition, when you think about digestion, it's really the small bowel that does the workhorse. So it absorbs all your proteins, fats, carbohydrates, vitamins, minerals. It's the small bowel where all that stuff happens. Now, when the small bowel is done, it drops everything off into the colon or the large intestine. I know I'd be getting to it eventually. Okay, so colon starts down here on your right side. I think I'm getting in my way of my picture. That's where your appendix is. Colon goes up, over, down, and around. Okay, I think Dr. Aslanian called it a horseshoe, which I think is a pretty good analogy. So every day when you're done with all of the waste from the small bowel throughout the day, it drops off about 32 to 48 ounces. So about a pint, slightly more, of basically just green waste, bile, and all the products that you're done with your nutrition. And the job of the colon is much, much simpler. So the colon of the large intestine, I like to think of it as a dehydrator. Think of it starting as a grape and ending up like a raisin. Okay, so each day that roughly 32 to 48 ounces of liquid is moved through the colon. It starts out as mush and then it becomes, more solid and then eventually becomes stored. And then lastly, it stops here in the last 15 centimeters or so, which is the rectum. Now, the rectum's a little bit different. I said the colon's just a dehydrator. It's kind of a dumb or a simple organ. It just basically takes out the fluid, move it down the line, move it down the line. This last 15 centimeters is a little bit more intricate, so to speak. So the rectum and then the anal canal, which is a 4 centimeter long muscle down here at the bottom, that acts as a reservoir. That holds your stool. That's what allows you to go to the bathroom, 3 times a day to every 3rd day. That's about the range of normal, but that's really where everything is held. I like to call it sort of your recycling bin or your garbage can. So you fill up your recycling bin or your garbage can, and then once a week, it's time to take out the trash. So the rectum fills up with stool throughout the day, and then maybe once a day, it's time to take out the trash. So that's its job, is to sort of hold on to things. And it's this very sophisticated, intricate mechanism, because if you think about it, your rectum and the anus can hold on to a solid, a liquid, and a gas, all three stages of matter, and differentiate which one to hold on to and which one to pass, right? You have this amazing mechanism of control. Imagine if you had that in your hand. I think you'd actually have a hard time differentiating holding on to the solid and the liquid and just dropping the gas. So the last 15 centimeters of the GI tract is really quite special, and that's the rectum and the anal canal. So when you get a colonoscopy with one of our gastroenterologists, what they're doing, as they described, is they're looking here on the inside and they're making their way back around. And what they're looking for is polyps, but again, we're here to talk about cancer. So what happens when you are in that unfortunate circumstance? So the other part of the GI tract, which I'm about to show you, is the liver. Okay, so the liver is feeding or getting all of the blood back from the GI tract. It processes all that nutrition and sends it out through the body. So when we get a diagnosis of a cancer, we want to know, is it something here, just in the bowel, or has any of that tumor broken off and has it spread to other places in the body? And so that's why before or after you see us, whenever you have a diagnosis of a new colon cancer, it's also important to get a CT scan of the abdomen and pelvis to look to see if anything has spread to the liver here. And we also include the lungs, because the chest is the next place where a tumor would spread. So when we get a patient with a new cancer, the question is it local or is it distant or spread? And the reason why that's so important is because that's really going to determine, for the most part, your next steps in treatment. Surgery is, for most parts, a local therapy. We can do surgery on the bowel, which I'll talk to you about. But when disease has spread to other parts, it's really about treating you as a whole. So that's where you would be talking with Dr. Johung or Dr. Cecchini, one of our colleagues from oncology, about treating you as a whole. So for the purpose of this sort of conversation, I'm going to talk to you about when the cancer is thankfully localized here just to the bowel. So the purpose of surgery and the goal is to remove the cancer safely. Goal number one, when I talk to my patients about treatment and surgery for localized colon cancer, goal number one is cure. Goal number two is function or form. So what does cure entail? So I've shown, just for this illustration, I've shown a cancer here in the right colon. So the purpose of surgery is we want to take blood vessels and any of the lymph nodes that drain from that, and we need to divide those and divide the bowel as well. Okay, so the bowel that all perfuses that. Now, a lot of people say, does this whole thing have to come out? The tumor's here. Why can't you just take this out? The thing that we need to do is ensure that we're getting all of those lymph nodes and any potential cancer cells that may have spread, so that we can give you a better idea of what's your next step in treatment. Now, after we've done that, we've actually taken the blood vessels as well. And so the next step after we've done our resection is we have to do a connection. And that's important to bring healthy bowel to healthy bowel. So for this example, done the right colectomy, we're taking out this part of the colon with the cancer, with the lymph nodes, and we want to bring well perfused with good blood supply to good blood supply. So connection from here to here. Okay. And how do we approach this? Like I said, goal number one is cure and making sure that we do the right cancer operation. But goal number two is trying to limit the stress on your body and any issues you may have after surgery. So let's see if I can get it shown here. I think you can see that. So I imagine if these are your ribs here, this is obviously a cartoon. Those are your hips. Move the camera a little bit. The way that and there's your belly button here. The way that we usually approach these cancers, if feasible, is through a minimally invasive, we can call that laparoscopic or robotic assisted surgery, but a minimally invasive approach. So in this instance here, what we end up doing is we end up making 1, 2, 3 stab incisions. They're what we call port sites. Those are each 8 millimeters, or about the size of my pinky. And through those, we're able to do this operation. Now, at the end of the day, These incisions are, like I said, about pinky sized, and this is probably 1.5 foot of your bowel. And so it just cannot be removed through those small stab incisions. It's one of the few sort of holdbacks, I think, about minimally invasive colon surgery, and that we still have to extract it. And so for the vast majority of people, what we end up doing is making a smaller incision here, right above the hips, which is called a phalansteal, or many people may be familiar with it from a C-section, and we are able to extract from there. Usually that's, you know, we make them usually 4 to 6 centimeters. So that is the approach to surgery. And if it's on the other, if the cancer is over here, we change the location of our ports. But again, it's usually port sites where the surgery is done, and then a small extraction. So what to expect after surgery, right? What are some of the hiccups, the recovery process? So the first thing after surgery, we want to make sure that you're recovering appropriately. You don't have any issues with your heart, lung, kidneys, that you're recovering well from anesthesia. And the next thing we would need to make sure is that your bowels have awoken and that you can tolerate something before going home. That's different. The amount of time you're in the hospital is different for different people. Some people it's 1 or 2 days. However, some people the bowels of the GI tract is just a little slower to wake up. So you may spend 3, 4, 5, 6 days. It really just depends on how quickly or slowly you can tolerate food. And it's different for different people. One of the reasons I personally really like doing minimally invasive surgery is because it allows people to leave the hospital more quickly. They have less pain. They can return to their lives more quickly. But there are some other benefits of it. It's, you know, when you're dealing with a new diagnosis of cancer, to me, my goal is not to have you spend 1 day in the hospital versus 5. It is somewhat important, but 10 years from now, that's not what I care about. And I don't think that's what most people care about. So one of the things I think that's important is, again, doing the right cancer surgery so that you can move on with things. And then number 2 is doing it in a way that I think you can recover more quickly. So that's sort of what to expect after surgery. Usually we ask people to limit their activity for a few weeks. In other surgeries, like doing open surgeries or making incisions in the midline, people worry about things like hernias. One of the additional advantages of doing the operation robotically or minimally invasively is, you know, we can theoretically limit those. In this particular incision, it can essentially be 0. But after surgery, after you've recovered, the next thing is the pathology. So we're going to get this specimen back here. And what we're going to be looking for is the cancer just here, or are there any involvement of the lymph nodes? A lot of people should say, what stage am I? And I say at the initial consult, I don't know. I will know not stage 4 based on the CT scan. So off the bat, I can say it's not distant based on the CT scan, but are you 1, 2, or 3? We need to wait for the pathology. And so that's usually the next step in treatment if needed. And that's usually a referral to like one of our colleagues, Dr. Cecchini, for example, who's on the call. The way I like to explain needing chemotherapy after colon surgery, if there are any disease in lymph nodes, it's possible things could be spread elsewhere. Okay, the analogy I use is you're in your kitchen. I'm actually standing in the kitchen of our office right now. It's actually a very nice kitchen. But anyway, if you're standing in the kitchen and you drop a glass or a plate, to me, surgery is picking up those big pieces of glass or the plate. Chemotherapy after is sort of like vacuuming or sweeping up those tiny little microscopic things that you may step on, which may hurt your foot. They could be there, they might not, but you don't know. And so the idea is just sort of clean up afterwards. Those are really the main things. I think the one other thing to talk about, I think I have 2 more minutes and then I'll stop, is what is your bowel function like after surgery? I think the biggest thing to understand, the reason I like to talk about the function of the GI tract, remember I said the colon is a dehydrator. So a lot of people say, well, how am I going to be going? How are things affected? The way I like to think about it is that you've lost some of that dehydration capacity. So more water is getting through. So you may, not everyone, it's actually less frequent, but you may have looser or more frequent bowel movements. And I think that becomes more and more of an issue as you get more and more downstream, because as you get downstream, you get into more of this, the high rent district, like I talked about, how the rectum is slightly different. So I hope that sort of gives you, if you're in that unfortunate situation, you have a new diagnosis of a cancer, what is the workup? Again, CT scans, seeing a surgeon, getting some blood work, what does surgery entail? And then what's your course after? And then what do you need after? And I think some of that, though, is in my personal practice, is that I like to let experts be experts. And I think any patient should get, as much of an opinion and as much input as possible. So even if the disease is if your cancer is just in the bowel itself, I send all of my patients to our oncologist just to have a discussion, because I think, if you don't ask the question, you don't get an answer. So I think hopefully one of the oncologists is going next. Is that true? All right. Thank you.
Well, thank you very much, Dr. Pantel. And that leads us really nicely into Dr. Cecchini from GI Oncology here at Yale. Came to us by way of California and Albert Einstein, and did the rest of his training here at Yale. Dr. Cecchini.
Thank you for having me today. Let me just get this up. All right, great. I'm gonna shift gears a tad here. So I am a medical oncologist. We've heard from our gastroenterologist thus far, our colorectal surgeons. And as a medical oncologist, I'm going to talk a little bit about personalized treatment for colorectal cancer, but I'm going to focus more on metastatic colorectal cancer. As medical oncologists, we are certainly involved a fair amount in giving chemotherapy and helping with decision-making after surgery to remove micrometastatic disease. But I'm going to focus mostly on the management of metastatic disease right now. These are my disclosures. So first, staging. We've talked a little bit about staging. I'll talk about how we think about this in terms of what we do in our treatments. And then I'm going to talk about some of the personalized treatments we do, which maybe some are familiar with from personal history, or many of these things are publicized now in the news and are important things to know for patients to know about their tumor. So staging. So we heard about the important power of colonoscopies as an initial diagnostic tool. That is how most colorectal cancers will be diagnosed, but there are other important tests that are done. There are blood tests, such as liver function tests. There are blood counts. There's a marker called CEA, which is a blood-based marker that may be elevated in colorectal cancer. Not all patients with colorectal cancer will have elevation of this. There's this sophisticated tool called circulating tumor DNA that we sometimes use. This basically can establish whether or not there's the presence of small fragments of tumor DNA. Our technology has evolved so much that we can tell tumor DNA in the blood, different from normal cellular DNA in the blood, and get an idea about what mutations might be present in the tumor, or just whether or not the tumor is there, period. And Dr. Pantel mentioned CAT scans or sometimes MRIs, but scans are necessary to establish whether or not there's evidence of metastases, the medical word for spread of the cancer from one spot of the body to the other. So when we think about cancer spreading from the colon, as you can see in the lower right-hand part of this figure here, this is the colon. So where my cursor is the right side. This part right here is called the transverse colon, and this is the left side of the colon. So a tumor, as we heard, will start in the colon, but unfortunately it can spread. Hematogenous spread through the bloodstream is the most common way. These tumors will also spread through the lymphatics, to the lymph nodes. And so these tumors, as they increase in stage, may spread again to an organ like the liver being the most common site of metastases or spread for colorectal cancer. Lung being another possibility, elsewhere in the abdominal cavity, another possibility, and other places to lesser degree. So if cancer spreads from the colon to one of these more distant sites, that is by definition stage 4 cancer. Stage 3 cancer means it's gone to a lymph node, but not more distantly. And stage 2 cancer means it's the cancer is localized to the colon, but has only has only gone through a few of the layers of the colon, and stage 1 is much more limited invasion to the walls of the colon with no spread. So stage 4 disease, when they're spread to the liver, is what we're seeing in this figure, starting in the left side of the colon, spread in the bloodstream, and then establishing a metastasis in the liver here. This is a radiographic representation of that. Of course, what I just showed you was a cartoon. So this is what we would call oligometastatic disease, cancer in one organ, in one site. So just to orient everybody here, where my cursor is the right side of the screen. Now the other side was obviously the right side of the screen, the right side of the patient, I should say. This is the left side of the patient. Then the top would be the belly and the bottom would be the back. So you can see that spinal bone there. We're looking up from this patient's feet, basically. So the patient is lying on the exam table here, the CAT scan table, and the CAT scan slices the body like a loaf of bread. And we can move our cursors to go up and down and look at those slices and get an idea of what's present. And so this light gray area, this lighter gray area, is the normal liver. That white stuff is contrast in the stomach, on the left side of this, on your right side of the screen, left side of the patient. And where my cursor is around right now, that's a tumor in the liver. So in this instance, there's a site of one side of cancer in the liver, so oligometastatic disease. This is important for us to have a multidisciplinary review with our colorectal surgeons, our surgical oncologists, our radiation oncologists, our gastroenterologists, our pathologists, to determine whether or not we think we can still do more than just chemotherapy and maybe even do surgery to remove these metastatic foci into endostatic areas of the cancer. So this is very important up front, despite metastatic disease being present, to have all of the potential team members at a place like Smilow involved to make the right decision plan for a patient. Because when we see oligometastatic disease like this isolated to one area, we can still potentially cure this cancer. But when the cancer is much more extensive, as you can see in this example, same exact orientation in a different patient, there's too many tumors in the liver to do a surgical resection here. There's not going to be enough healthy liver left behind for a patient to get through an operation like this. So in this instance, we might do chemotherapy in the example I showed you before, but we might do it with a goal to get to the surgery. In this instance, surgery is really going to be the therapy that we have available here. And its goal is different. Well, we may hope to get that patient on the prior page to cure. In this instance, our chemotherapy is given with different intent: palliation, prolongation of life, improvement of any tumor-related symptoms, and delaying the onset of new tumor-related symptoms. So different from our goal of cure when there's more limited metastatic disease. And our goal is also cure with the examples that we've heard previously by our gastroenterologist, diagnosing localized disease primarily. And when Dr. Pantel is operating on the colon, generally our goal is cure as well. So more limited disease than I'm showing you here. So then when we know that we're going to have to primarily use chemotherapy, there's a lot that goes into personalizing the treatment plan for somebody. Colon is a very unique organ, and it is of different embryologic origins when our bodies are forming. And it therefore, where the tumor rises in the colon tells us a lot about the different genomics, the different DNA of the cancer, and different other molecular characteristics when we sequence cancers and we do things like methylation, even clinical factors like women are more likely to have right-sided tumors. Early onset that we heard a little bit about is more likely to be on the left side of the colon. And that we think has to do with this embryologic origin of the colon tissue. We use this also as information to determine which chemos will work better. We know that certain drugs, like a drug called bevacizumab, for example, will work better on a right-sided tumor, and drugs like cetuximab or panitumumab, which I'll talk about, will work better on a left-sided tumor. So this anatomy is very important. We heard a little bit about from our gastroenterologist that these cancers start as a small polyp. So there's normal cells lining our gut. A small adenoma, small polyp will form. It'll become larger, and then what can happen is invasive cancer can form in that polyp and invade into the wall of the colon, essentially. Usually there's two main pathways that will kick this off. And these are molecular pathways at the on the cellular level, where either a tumor may be microsatellite instability high or mismatch repair deficient, which are highly mutated tumors responsive to immunotherapy, or more traditional, there'll be mutations in something called APC or beta-catenin. The latter representing the majority of cancers we see. So this speaks to why tumor profiling is so important. So certainly at a place like Smilow, we are sequencing virtually every metastatic tumor, at least, to help personalize the care and personalize the treatment. So a sample of the tumor will be sent to our lab, or in some instances sent out to other labs, to determine what unique mutations are present in the tumor, not in the normal cells, but in the tumor. These tumors become abnormal and acquire mutations. And we leverage that information to use perhaps more effective drugs or different drugs to make sure we're meeting the needs of our patients. There's also liquid biopsies, as you can see, that little blood tube there, where we will use blood to try and detect circulating tumor DNA or remnants of the tumor DNA, and also get some similar, or in many instances, the same information, and understand what's making that tumor tick just by a blood sample. So the first step is we do some immunohistochemistry. So we stain the tissue. Our pathologists look at the cancer cells, and they do some stains on it, and they tell us whether or not there's mismatch repair protein expression, so that's mismatch repair testing, or whether or not there's HER2 expression. These are tests that every patient with colorectal cancer should have. So if somebody is diagnosed with metastatic disease, I think it helps people be informed about their care, and you should feel free to ask your doctor the results of some of these tests. Is my tumor mismatch repair deficient? Is it proficient? What does that mean? And your doctor will be happy to talk with you about the relevance of that and the status. But then we, again, do this DNA sequencing to look at mutations in KRAS, BRAF, we look at NTRK, and we look at HER2. By that means as well, to determine which treatments might be best. So these are the most important characteristics, and I urge every patient that may be diagnosed with this cancer that to perhaps try and ask your doctor about these factors in your circumstance. So when I'm training fellows at our institution, I always try and tell them, if they can only transmit a certain amount of information in a sentence or two to me, that these are the things I absolutely need to know to help guide the treatment. And so that's the microsatellite status, because we have immunotherapy for the rare circumstances we find microsatellite instability high or deficient mismatch repair tumors. And this completely changes prognosis and treatment very dramatically. Then KRAS mutations, we need to know that because that helps us determine medications like bevacizumab versus cetuximab or panitumumab. BRAF mutations, because we have targeted therapies for that mutation. That's about 10% of colorectal cancer. KRAS being about 40%. Microsatellite instability high being just about 2 to 4%. And then HER2 status, about 4% of cancers will have amplified or overexpressed HER2, which we have targeted therapies for that. And I already told you about the importance of left versus right. So these are all factors that are extremely important to make sure you're getting the best care. We use a lot of abbreviations because our drugs have complicated and convoluted names, frankly. So we use the terminology FOLFOX or FOLFIRI, or sometimes we mash up all the drugs into one regimen and we call that FOLFOXIRI. So these are the chemo regimens that we'll typically start with. We usually start with FOLFOX, and we may add on a drug or two to that based on some of those mutational statuses that I talked about, or FOLFIRI, which is another chemotherapy that we'll usually use second here in the United States. In some circumstances, we'll use all three drugs at once. Frankly, this is more toxic, and patients certainly need to be relatively healthy to receive all three drugs at the same time. And sometimes we'll drop the third drug and just move on with two if it's too toxic for people. So like I said, we'll add in red there, we'll add on a medication called bevacizumab, which starves the tumors of basically oxygen supply that they desperately want, or we'll use panitumumab or cetuximab if there aren't mutations in KRAS or BRAF. So we call these biologics. So we use the mutational status, that sidedness information, to add on the optimal biologic to the chemotherapy and deliver the most effective regimen to the patients and the tumor. So this is a pathway in a cell. So if we see this gray half circle here, this is meant to represent the top of a cell, and that this little thing here is a receptor on the surface of the cell. This is how a lot of cells function. There are receptors that are hijacked and become active and just tell a cell to grow. It's just like a light switch, and it's just on all the time. Grow, grow, grow. That's unfortunately what cancer wants to do. And so when we see a mutation in something like KRAS, that first boxy thing there, or BRAF, that's part of this pathway that's just activated. So we look for these mutations to determine where we can target the tumor. And if we don't see any of those mutations, we know we can use certain medications. And if we do see a medication in KRAS, we know that we'll use primarily a medication called bevacizumab. So I use that information with the initial sequencing, which I'm getting as soon as I see a patient, if it hasn't already been sent by another another member of the team, to determine, do I add bevacizumab or do I add cetuximab or panitumumab? These green, the drugs in green there, again, bind to that receptor. There's been a lot in the news about targeting KRAS. And so KRAS is, again, 40 to 50% of colorectal cancer. We have drugs that inhibit a rare subtype of KRAS, maybe 2% of colorectal cancer. And now one is called sotorasib. And so sotorasib and panitumumab are approved. There's another drug that's pretty far along called adagrasib. These drugs are very meaningful for the patients that have this rare subtype of KRAS G12C mutation, so something I am always looking for. We have new drugs in clinical trials, which I'm involved in, targeting KRAS G12D, other KRAS mutations as well. These are absolutely personalized medicine. We're giving the right drug to the right patient at the right time. We've come a long way as a field in developing these drugs. They're really going to change things over the next decade. We have drugs that target BRAF, another part of this pathway. So for about the 10% of people that have a mutation in their tumor in BRAF, we have a targeted therapy. We're not just giving chemo to every cell in the body. It is targeted therapy to the cells that have the BRAF mutation. And encorafenib is cetuximab, and that's been approved for about 3 years now. And for the circumstances where there's a HER2 amplification, again, a HER2, another part of this receptor this pathway, basically, we have 2 oral drugs, one oral drug and an IV drug that inhibit this pathway as well. And we have another drug called Enhertu, which is widely known in the breast cancer literature and in gastric cancer literature, that will also work in these circumstances. So I'm looking for these rare markers, this one being about 4% of colorectal cancer, because I have these targeted treatments that are very meaningful. For 96% of patients, these might not apply, but for the 4% or so that have this mutation, very, very meaningful. It changes dramatically what I do. And as we talk about understanding the molecular characteristics of colon cancer, 4% here, 10% here, another 4% there, it really adds up to a substantial number of patients that are getting their treatment quite a bit personalized by these genomic characteristics. This is one of the most critical of them, though, the role of the immunotherapy for colorectal cancer. So this is an example here. You can see on the far left is a tumor cell. In the middle is a T cell, one of our main immune cells. In the far right is a dendritic cell, which is a cell that helps our immune cells recognize things as foreign. So recognize the tumor as foreign or abnormal or bacteria or something like that. So we have drugs essentially that take the brakes off of the immune system to attack and kill the cancer. The classic examples in this disease would be nivolumab, pembrolizumab, and then there's another drug called ipilimumab that are all either within guidelines or approved in this disease for mismatch repair deficient, for the 4% or so of metastatic colorectal cancer with this condition. For about 95, 96% of patients with metastatic disease, unfortunately, the immunotherapy doesn't necessarily apply outside the role of clinical trials, which we are very active in trying to figure out how to make immunotherapy work for microsatellite stable or mismatch repair proficient, the more common type of colorectal cancer. But for the rarer subtype of around 4% of patients with metastatic disease, we use immunotherapy instead of chemotherapy. This is why. So this is what some data that comes out of clinical trials. We look at how well our drugs are working. So all of these tumors in this figure here, on these figures here, are microsatellite instability high circumstances. And on the left axis, you have patients that are alive without their tumor growing in both of these graphs here. This is with one immune drug, and you can see that pembrolizumab at about two years patients are alive without any growth of their cancer at about 50% of the time. At 2 years, you can see these later time points, but the longer you go in this, there hasn't been enough follow-up to really know exactly what the numbers are this far out. This is compared to chemotherapy, where about at 2 years, we're talking about just 20% of patients without their cancer growing. So immunotherapy really changed how patients with this rare subset of colorectal cancer do. I certainly have patients that seem to have had their cancer go away more or less completely, and maybe are off immunotherapy altogether. This is just very recent, in the last 2 months. This is 2 immune drugs. This is nivolumab and ipilimumab, and now we're looking here, instead of maybe around 50% at 2 years, we're seeing 72% at 2 years. And we're not comparing these two regimens directly head to head, but you can see that we have made some dramatic strides over what chemotherapy has done for this rare subtype of colorectal cancer. So in conclusion, multidisciplinary care to determine whether metastectomy or other local treatments like radiation, ablation are warranted is absolutely critical. And at Smilow, we are a big team. We review cases together frequently, and we definitely provide that multidisciplinary care quite effectively. As medical oncologists, we use FOLFOX and FOLFIRI as the main initial therapies for metastatic colorectal cancer. The things to look for are these green check marks, which seem to have gotten out of whack, but microsatellite status to know, KRAS to know, BRAF to know, HER2, these are markers your doctor should know. I encourage you to know about these as well. And immunotherapy for microsatellite instability, high colorectal cancer is absolutely the standard care and has changed this disease. Thank you so much. Happy to field any questions.
Thank you so much. I have a couple questions in the chat. Are the actual rates of oligometastatic disease going up?
I'm sorry, can you repeat the question? I was coughing.
Oh, sorry. Are the rates of oligo, we talked about colon cancer rates increasing, but are we seeing a higher rate of oligometastatic disease?
Not precisely, but I think how we manage oligometastatic disease has evolved. It used, I think, with more advanced local therapy techniques about things like ablation or radiation to certain areas and surgical techniques, we define oligometastatic disease a bit more broadly than we used to, because we feel that, for example, multiple liver metastases all in a relatively similar region of the liver can still be treated as oligometastatic disease. There are even circumstances where this really oligo, meaning one, where we see metastasis to the lung that are relatively limited and metastasis to the liver. There are circumstances where we will try and remove both of those areas surgically, if feasible, or with a combination of surgery and local therapies.
Wonderful. All right. We're going to move on next to Dr. Kimberly Johung, who comes to us from our Department of Radiation Oncology. She's spent her entire career here at Yale, and we're really lucky to have her.
Thank you, Dr. Mongiu. All right, let's go into slide view. That works, right? Okay, so I happen to have a very similar title to Dr. Cecchini. We didn't plan that, but I think it's going to work out well. So I'm going to be talking about radiation therapy for rectal cancer treatment. And as we heard about tonight, treatment of rectal cancer involves 3 standard therapies. Dr. Pantel talked to you about surgery. Dr. Cecchini talked to you about chemotherapy. And I'll be talking to you about radiation therapy in the management of rectal cancer, and trying to gear this talk towards how specific radiation can really be tailored to specific characteristics of a patient's tumor, and also a patient's goals of care in their treatment program. So what is radiation? Radiation therapy is the use of ionizing radiation, typically to kill cancer cells. We also use radiation therapy for some benign conditions. Most often radiation is delivered by a linear accelerator. This is basically a machine that generates high energy X-rays and directs the radiation with high precision towards your tumor. What does radiation do? It damages the DNA of your cancer cells, leading to cell death. So pictured here is a linear accelerator in a standard typical treatment room, a vault we call it. Side panels on this machine, which are these right here, are used for imaging. So when you come in for your treatment, you lie on this treatment table, and the imaging panels are used to make sure that your body is perfectly aligned for treatment. And then this head of the machine is called the gantry, will arc around your body, delivering radiation, targeting your tumor from all angles. And to spare the normal tissues, such as the skin that the radiation passes through, or other organs, healthy organs that the radiation must pass through to treat the tumor, we basically aim the radiation beams from several different angles or a full arc around your body. And those beams will intersect in your tumor volume, such that the prescription dose is delivered to the tumor, and the surrounding tissues are exposed to a much lower dose of radiation. So how are the beams shaped? So they're shaped from each angle to match the shape of your tumor volume. And this is achieved by these multi-leaf collimators up in the head of the machine. You can see them here, and this is a close-up view. These are millimeter thick tungsten leaves, and they will move independently in and out of the path of the beam. So as they're moving in and out of the path of the beam, not only are they shaping the beam to fit the shape of your tumor, they're also modulating the intensity of the beam across the face of the beam. So think of it like a flashlight. So it's basically allowing the beam to penetrate exactly to the depth of your tumor from that angle. So really with the use of these leaves in the head of the machine, we're able to deposit a dose of radiation that will match the three-dimensional volume and shape of your tumor. So what is the radiation sort of care path, and what would a patient go through in order to complete a course of radiation treatment? So like most scenarios, you would start with a consultation to determine if radiation is helpful in your treatment plan, discuss risks, benefits of treatment, etc. And this would be followed by an appointment called a CT simulation. This is really a planning process. We position your body how it would be positioned for treatment. So most often for rectal cancer patients, we would place you prone in a device called a belly board. I like to tell my patients it's like a massage table. You have a little hole where your face would look down. This allows your normal bowel to fall forward out of the radiation field. It helps reduce side effects. Once we have you in the treatment position, we'll obtain a CAT scan of you in that position. And we use those images to plan your radiation. And this is really a process that's done in collaboration with physicists, we call them dosimetrists, to determine how to best target your tumor, avoid the normal tissues. Plan goes under a QA process with our physics team, and then it's ready to go and for treatment. And this is a picture of a patient being treated. So after the CT simulation, we identify the tumor target, as well as all of your healthy organs in your pelvis, slice by slice through the CT scan, and devise a treatment plan to target the rectal cancer. Also shown here are the lymph nodes that would be at risk for rectal cancer spread. We typically deliver treatments daily. So radiation treatments are delivered Mondays through Fridays over the course of for rectal cancer, typically 5.5 weeks. And why do we do this? This is because cancer cells have a decreased ability to repair the DNA damage that's caused by radiation. Normal tissues are better able to repair the damage. And so if we call this fractionation, if we deliver the radiation in small daily doses, this will preferentially damage the cancer cells where the normal tissues are able to heal. We typically, for rectal cancer, deliver radiation with a chemotherapy pill. The chemotherapy pill synergizes with the radiation, acting as a radiation sensitizer. And then for certain patients, and I'll talk about this a little bit more in the next few slides, we deliver radiation in 5 larger doses, and that's typically done without chemotherapy. So to get into a little bit more of how we would tailor the radiation for a particular tumor, I know Dr. Cecchini mentioned this briefly, but I think it's helpful to touch upon how rectal cancers are staged. So rectal tumors are staged based, shown here, on the depth in the wall of the rectum, and then whether or not they have spread to lymph nodes and how many lymph nodes they've spread to. And radiation prior to surgery would be considered standard treatment for tumors that are staged as T3 or T4 based on depth, or tumors that have spread to the nearby lymph nodes. And this is data shown here from 2 studies that showed basically that radiation, the benefit of radiation for these more advanced tumors, so tumors that are more advanced in the pelvis but not yet metastasized, is local control, meaning after someone like Dr. Pantel does the surgery, the benefit of radiation prior to the surgery is that it can decrease the risk that the cancer can grow back in the pelvis after the surgery is done. Another benefit of radiation is that if your tumor is lower in the rectum, the radiation prior to surgery can also improve the likelihood that your cancer can be removed while sparing the sphincter muscles for continence, so to avoid the need for a permanent colostomy. So I'm going to go back to these two studies, because in these two studies, in the Dutch trial that was looking at the benefit of radiation, the radiation was delivered in 5 large doses without chemotherapy. And in this German trial, the radiation, it was comparing preoperative radiation to postoperative radiation. The benefit for local control was larger when the radiation was delivered preoperatively. But the delivery of radiation was different here. As I mentioned, we most often give radiation daily over 5.5 weeks with chemotherapy, and that's how it was done in this study. So we refer to these two types of radiation courses as short course radiation. That's the 5 larger treatments without chemo, or long course radiation delivered with typically a chemotherapy pill. So how do we determine when we would select short course versus long course radiation? So there are studies that have looked at comparing these two regimens of radiation. And basically the outcome is that the survival for patients, rates of local control, and even the toxicities of the treatment course were similar if you use either short course or long course radiation. But if we look a little closer, for those patients who had distal tumors, and these are the tumors that are developing very close to the anus, so less than 5 centimeters from the anal opening, the rates of recurrence seem to be higher with the short course radiation option. This is getting a little bit more technical, but what I want you to focus on with this study is we are looking at a population of patients with high-risk rectal cancer, and half of them had the long course chemoradiation, the 5.5 weeks with a chemo pill, and the other half had a short course of radiation, the 5 large treatments without chemotherapy. This study also asked a different question of timing of the IV chemotherapy, whether it came before or after surgery. We'll talk about that a little bit later, but let's focus on the long course versus the short course comparison. With the benefit of radiation being local control, prevention of tumor growing back after surgery, what we're seeing in this comparison of the short course and the long course is that the risk of regrowth in the pelvis was higher with the short course regimen for these high-risk rectal cancers. So from those last 2 slides, when we're deciding between the long course regimen or the short course regimen, and I'll say we more commonly use this long course regimen with chemotherapy, but would certainly prefer it for those tumors that are low, very close to the anal opening, those high-risk tumors that were studied in the study on the previous slide. And then something I'm going to talk about a little bit more later is that the long course is commonly used in patients who are seeking organ preservation or avoiding the surgery that Dr. Pantel described. Okay, so let's go back to this one study that was looking at the short course versus the long course, but also asking the question of chemotherapy before surgery or chemotherapy after surgery. Sorry, that would be the upper one. So this approach of giving all of the therapy prior to surgery is called total neoadjuvant therapy. And that in this study was compared to the standard approach, which would be to start off with your radiation, then have surgery, then follow that with chemotherapy. And we're again looking at the high-risk population of rectal cancer patients. And what you see in this study actually is that if you give the chemotherapy and the radiation all before the surgery, outcomes in terms of treatment failure were decreased significantly with the total neoadjuvant approach. And that's probably because we are seeing in those patients that their likelihood of distant metastases was also decreased. And this is another study looking at this total neoadjuvant approach. basically looking at it with a different chemotherapy. There's one more agent added in here, so a combination chemotherapy called FOLFIRINOX. One of my patients calls this the Fluffy-nox to make it sound more friendly. She did not like her infusions. So with this approach, with the FOLFIRINOX chemotherapy and the long course chemoradiation, followed by surgery, so a total neoadjuvant approach with a FOLFIRINOX chemotherapy versus the standard approach, again, we're seeing overall survival improved. So the total neoadjuvant approach, I would say, has become a standard for high-risk patients, and that would be receiving your radiation and your chemotherapy before surgery. So an important consideration, we're talking a lot about the data and the outcomes, but we also want to consider how best to preserve quality of life and balance quality of life with best cancer outcomes. So we know rectal surgery obviously can be associated with poor bowel function after the surgery, and adding radiation along with rectal surgery obviously can lead to other long-term functional deficits, including affecting your bowel function, your bladder function, and your sexual function. So this brings into question, are there some circumstances where organ preservation or trying to avoid surgery can be considered? And are there some circumstances where you can try to omit radiation from the treatment program for locally advanced rectal cancer? So let's start with the possibility of organ preservation. So this cancer patients that had stage 2 or stage 3 disease. Half of them were given their pelvic radiation with chemotherapy and then chemotherapy, IV chemotherapy. The other basically had the regimens reversed in terms of order, so leading off with chemotherapy and then having the pelvic chemoradiation. So you're trying to take that total neoadjuvant approach of everything before surgery, but then pausing and saying, well, before we go straight into surgery, can we evaluate patients and see if there are any that may have had such a good response to the chemotherapy and the pelvic radiation that they may be able to avoid surgery. And they were basically evaluated with a rectal exam, a sigmoidoscopy that our gastroenterologists have talked about earlier in the session, and an MRI to look at the response to the chemotherapy and the radiation. And it turns out that about 3/4 of them had a complete response and were offered something called active surveillance or watchful waiting. So what do we mean by that? So active surveillance or watchful waiting entailed a rectal exam, a sigmoidoscopy, every 4 months for 2 years, and then every 6 months for 3 years. And then an MRI every 6 months for 2 years, and then every year for 3 years. And in this study at 3 years' time for follow-up, surgery-free survival, meaning you're alive and you did not need to have a rectal surgery to cure you of your rectal cancer. 3-year surgery-free survival was 41% if you had your chemo first, 53% if you had your chemo radiation first. And what's important is that the patients who had their surgery up front, meaning they went straight from their radiation and their chemotherapy to surgery because they did not have a complete response to those therapies, versus those who required surgery because they recurred after the watchful waiting program, their disease-free survival was actually similar. The other main take-home point is that organ preservation, meaning not needing surgery, was achievable if you average these in about half of patients. And in those patients where organ preservation was achieved, their survival was similar to historical controls, meaning other patients treated with the standard approach of pelvic radiation, surgery, and post-op chemotherapy. All right, so what about potential emission of radiation? So selective use of radiation was studied in this prospect trials. This is looking at a more favorable subset of the patients where you would consider pelvic radiation. And these patients, basically, half of them had standard pelvic radiation with chemo, followed by surgery, followed by IV chemotherapy. And that was compared to patients who led off with the chemotherapy and then had an interim MRI to assess response. And if response greater than 20% was seen by MRI, these patients did not have radiation and went straight to surgery. And for those patients who had less than a 20% response, which turns out to be less than 10% of patients, so most patients are responding to the chemotherapy. But if you're in that 9% of patients who did not respond by MRI, you did have the standard pelvic radiation, surgery followed by chemo. So we do have a group here that avoided radiation. And what happened to these patients and what were their outcomes? So it turns out that with upfront chemotherapy, the FOLFOX chemotherapy, and an interim MRI to select radiation basically to be used only in the less than 10% who didn't respond to FOLFOX, there was no difference in terms of local control, disease-free survival, or overall survival. And based upon this data, I think we are now in our treatment program saying that, or considering that it's safe to emit radiation for select tumors, those that are higher in the rectum, where we're not trying to preserve the sphincter with pelvic radiation. Earlier stage tumors, the T2, T3s, with involvement of maybe just a few lymph nodes, and certainly those patients where surgery is planned. And in that study that we talked about, patient-reported outcomes were collected, and during what they see is during preoperative therapy, patients who received the FOLFOX chemotherapy first did not receive radiation. So with the emission of radiation, what are the benefits? The patients are reporting lower rates of diarrhea, better overall bowel function. The patients who did have pelvic radiation as part of their treatment course obviously are and not the FOLFOX chemotherapy prior to surgery. So without FOLFOX chemotherapy in the pre-op setting, the side effects that they're reporting less of are the side effects that are typically associated with chemotherapy. So I think the take home from this is that if you avoid radiation in the pre-op setting, these patients are experiencing less diarrhea and better overall function. More importantly, if you look long-term, so a year after surgery, for those patients who did not have radiation, this was associated with lower rates of fatigue, lower rates of neuropathy, better overall sexual function. And another important point is that the emission of radiation is important to consider in younger patients, younger women who desire preservation of fertility and ovarian function. So I'll summarize by saying that pelvic radiation has a key role in curative therapy for locally advanced rectal cancers, but we can tailor the use of radiation based on your tumor characteristics and goals of care. We are considering emission of radiation for select patients who have what we would consider a more favorable rectal cancer higher up in the rectum by MRI, those who are candidates for surgery, and not interested in organ preservation. We would prefer this total neoadjuvant approach of starting with chemotherapy and your pelvic radiation, so basically throwing everything at you before surgery for those patients with higher risk rectal cancers, those that have not yet metastasized. And there are two ways of giving radiation, the long course radiation or the shorter course radiation without chemotherapy. And we make that decision based on these risk factors. So preferring long course radiation for the higher risk tumors, those that are lower in the rectum, or in patients who may be trying to use radiation and chemotherapy and hoping for a great response in order to preserve the rectum and avoid surgery. So I'll end there and thank you and take any questions, I think, for the whole group at this point, right?
Thank you so much, Kim. Yeah, I think at the moment I see nothing in the Q&A that's open or in our main chat. Anyone have any final parting comments?
We did great on time. 3 minutes to spare.
Excellent. All right. Well, seeing no further questions, I'd just like to thank everyone for coming tonight. It's our pleasure to get to talk with our patients and to answer some questions and to talk a little bit about how we take care of colorectal cancer patients here at Smilow. All right. Well, have a wonderful evening. Take care.
Thank you.